Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record. Also, please remember to fill out the program evaluations that I think everybody got on the way in today. And if you could give the CME committee any ideas in regards to future topics or speakers, we would be appreciative. Today, I have the pleasure of introducing Dr. Larry Otteman. Dr. Otteman has been a frequent contributor to Grand Rounds, and I think, as I've probably previously mentioned, when we establish a Grand Rounds Hall of Fame, I'm sure he's going to be a charter member. Dr. Otteman is board certified in Hematology, Oncology, and Palliative and Hospice Care, and he's the co-medical director of the Homeward Hospice, and he's here today to update us on advanced care planning. And please join me in welcoming Dr. Larry Otteman.
Thank you, Steve. So today's visit will be, the slides are a little bit wordy. I apologize for that. I made a slight change in order, so don't be thrown off as you go through the handout. What I really like at the end of this 45 minutes is that people have a little bit of a sense of what's wrong. That's actually kind of a straw man. It's just you can, and there are hundreds of articles written about what's wrong. I thought it would be helpful to understand that it's not just what's wrong, but that there are an increasing number of resources available, and we've tried to make some of those resources available to the providers, both in the community as well as at the hospital. And then I thought it would be of interest to hear some voices of people who have had a chance to really think about this, because that's clearly the biggest deficiency, is that nobody wants to spend time thinking about these things. So let's talk a little bit about the deficiencies in advanced care planning and then move on to some proposed solutions. If people have burning questions, you certainly are free to interrupt me, and there'll hopefully be time at the end of this to answer questions as well. I like starting with this summary. I've never met Dr. Perkins, but he sounds kind of crusty, and I like that, so we'll start with his comments. And he points out in this article now 8 years ago that there are lots of really flaws, fundamental flaws in the assumptions that we make as we approach people about making advanced care planning decisions. One is that people think about their end-of-life care. They don't. That advanced directives can control what's going to happen to you, and Dr. Perkins says, no, they don't do a very good job. And that even if we fill out these advanced directives, well, you know, even if they're useless, at least they won't complicate things. And he says even that's too much to hope for. So he finds lots of problems with the written advanced directives that were available at the time he wrote the article. The process of getting advanced care planning is flawed. First of all, if you're going to sit down with a patient and their family, you have to have time. That's a rare commodity, which becomes even more rare with each year, it seems to me. It's helpful to have a checklist that even after people think about completing an advanced directive, oftentimes they don't do it at all. They don't understand the terms, particularly with regards to cardiopulmonary resuscitation. They may change their minds and just never get back to altering the document. That once the document is completed, that nobody can find it, that they forgot to name a proxy, or the proxy they chose was their next door neighbor to whom they'll no longer speak, or a child to whom they no longer will speak, and that even if you present it to the physician may say, well, I'm not going to do that because that's not comfortable for me to do that. So Dr. Perkins says there are lots of problems. Interestingly, he looks to Albert Camus, a author that many people may be aware of, and he derives these, I think, interesting points about life, which kind of guide Dr. Perkins in what he thinks are really important. One is life is unpredictable. We don't have control over it, but it does have meaning. That The one thing that really counts is what he calls authentic communication. I think that would be a good conversation about what you'd like at the end of your life. And that times that are trying or challenging shape and reveal character. And so Dr. Perkins says from his thoughts about advanced care planning, what he comes away with is that a provider to that patient and family should point out that simply filling out a document's not going to be enough, that the family needs to prepare for the fact that there are going to be decisions to be made. And I think importantly for Dr. Perkins, as he saw this was lacking as medicine evolved, is that the provider should share responsibility for the decisions made and not simply say, well, it's up to you, whatever you want to do as a family. And that if there's a greater duty that we have to our patients and survivors, is that to bear witness to their suffering. I think a good place to start from, and another way of looking at advanced care planning. This is another list, and simply is kind of a list of things that have people have spoken to this doctor, Dr. Freed, in his attempt to carry out discussions about advanced care planning, and you can read them. I don't want to think about the end of my life. That's pretty common. I don't know what a living will is. My kids will make the right call. I don't need to worry about it. My doctor will make the right call. I don't need to worry about it. God will make the right call. I don't need to worry about it. And I don't have anybody that can act as my surrogate. Sad but true for some people. This one I liked. I don't want someone to say to pull the plug because I signed this thing. And then a pretty common one, I can't talk to my daughter, my son, my children because they'd fall apart if I had the discussion. All of those are common responses when we approach people about discussing making decisions. There is a prominent report from the Institute of Medicine that was published and released in the fall of 2014 called Dying in America, the subtitle Improving Quality and Honoring Individual Preferences Near the End of Life. It's a long, thick tome. And they came up with 5 recommendations, what they called core competencies. And this is the opening quotation in that book from Goethe. Knowing is not enough, we must apply. Willing is not enough, we must do. And I think that's a very fair generalization about advanced care planning. So these are their primary recommendations. They talk about payers. Payers should pay. They talk about organizations. Organizations should be organized about these things. Measurable, actionable, evidence-based. And clinicians, those of us in the room, we should be competent to have these discussions, or the organization should have the competency to have these discussions. Again, payers should be willing to pay in an integrated fashion, so that if we are saving them money, and that's what we do, oftentimes with advanced care planning, is that they should be willing to plow some of that money back into supportive services, which make the quality of our patients' lives better and makes our job easier. And then I didn't highlight this whole thing, but consider them everybody. Employers, cities, public health agencies should encourage people in this effort. And we were lucky enough to have a discussion from the people from La Crosse, Wisconsin, who have done precisely that. They've engaged the entire community of La Crosse, Wisconsin in focusing on advanced care planning. So those are the 5 recommendations, and this is what they would measure, and it's all about measurement these days. So I suspect that there will be some elements of this that we will, if people consider advanced care planning a sign of quality of care, and maybe even value care, that there's frequent assessment of the patient in all of these domains, that we help patients manage emotional distress. We offer referral to palliative care, referral to hospice, and that there is a team effort between the primary care provider and other specialists or people with expertise in the organization. They recommend that once people have signed into this idea of, I need support from the organization, that support be available around the clock. We focus on symptoms such as pain and other symptoms, that counseling be available, that the family caregiver receives support, and that attention be paid to social, spiritual, religious needs, and then finally that the plan be regularly reviewed and revised. That's a tall order, but those are all of the elements that the Institute of Medicine and the task force presented, and you can imagine that payers love lists. Are you doing this? And so this will be a list that we will see more than once, I'm sure. Again, I referred to the work that's been done in La Crosse, Wisconsin through Gunderson. It's a program called Respecting Choices. Stephanie Anderson gave a very nice presentation here about 6 weeks ago. And just to briefly borrow from her slides about what the problems are, and to begin suggesting that there are some solutions. One is that the prevalence of advanced directives is low in the general population, about 25%, and even those who most need the documents, those at the end of life with their illness, there are less than 50% of patients. And again, they're often unavailable where you need them. They're often not helpful because they're too vague, and they oftentimes are not followed, not because of ill will or ego problems among providers, but they're ambiguous, or the loved ones don't support what their family member put down. These are the promises that Respecting Choices makes. And I think that's a good way to begin thinking about how can we improve the system? What promises are we making? And I think everyone can read that. We promise to start the conversation, to assist in the conversation and the planning, to try to make the plans as clear as possible through dialogue between the patient and the provider. We'll maintain the plan and be able to retrieve it, and we promise to follow the plan. Pretty simple promises, but again, as a checklist goes on, Respecting Choices is proud of the fact that those promises serve as their chief measure of competency. Let's see, I need to go back one. Sorry. And then what are the benefits of this process? And again, Ms. Anderson pointed them out. It improves patient care through the obvious things. It improves population health. That's another big topic as we get into accountable care organizations. It improves patient and family satisfaction, and I'll show you a very interesting study done in Australia using the Respecting Choices paradigm. And particularly, there is a lowered cost of care. I think the most direct comparison, and she provided this, was between La Crosse, Wisconsin and Des Moines, Iowa. It's not huge, but it's not insignificant either in terms of the cost of care of patients in the last 2 years of their life. So those are the things that Gunderson in La Crosse, Wisconsin has started to do. This is a very interesting study that used Australia's adoption countrywide, amazingly enough, of the Respecting Choices program. This was a study out of Victoria, Australia, in an academic hospital. There were over 300 patients that were identified by their age, over 80, and they needed to be followed for more than 6 months. The program that they use is based on respecting choices versus just what they normally did, standard of care. And of these patients, they came up with these statistics that people liked using it, that 86% were willing to express their wishes, express a wish about CPR, and about discussions about life-prolonging treatment. So people were not adverse to having these conversations, and that's what all the data shows. Again, one of the core competencies, and that is that as they followed patients, over 90%, their wishes were followed. Gunderson's percentage is even higher. I think one of the most interesting things, because one of the core measures of value of care is not necessarily a blood pressure, a glycosylated hemoglobin, but patient satisfaction, which seems appropriate. It was amazing the difference in the satisfaction that patients expressed, patients and their families expressed, using either the respecting choices approach or the standard approach. These are pretty striking. 93% satisfaction with the care they received at the time of their discharge from the hospital. 86 felt that they had had valuable information provided to them, that 94% felt that they had been listened to. The family felt involved, and they measured stress, depression, and so on, and they were all lessened. And so this, not simple, because it takes time, it takes people, it takes training, it takes competency, but basically being willing to sit down with families and patients and have the conversation pays big benefits in terms of satisfaction. And satisfaction is going to be, I think, a measure of the value and quality of care that we deliver from here on out. Let me switch a little bit, if I may, then to what's out there, what's available to you and to our patients. First of all, let me brag, or at least inform you a little bit about what we are currently doing in Ames, both at McFarland Clinic and at Mary Greeley. The first thing is nothing that we had anything to do with, but in fact, the Center for Medical Services, CMS, has developed a code and payment for advanced care planning discussions that is in the Epic system, and people are using that. There's also, dating back now a few years, iPost, the Iowa Physician for Life-Sustaining Treatment legislation. The iPost forms have been available in Iowa and are a matter of law since 2002. At McFarland Clinic, we have had for 30 years this document, which has been revised. Hopefully people recognize it. It's simply called the McFarland Clinic, the Medical Directive. And of all the years that I've practiced and the things that I've read, it's still, I think, one of the single best documents available to our patients. Every provider in this organization and at the hospital has these available. More recently, at the urging of Dr. Hallberg and through the help with Shelley Jakey, every provider should have available this, which is called Starting the Conversation, so that if people are interested or if you want to introduce the idea of advanced care planning and starting the conversation, which is what it's about, you have this available to give to your patient, hopefully to be followed by either a return to the office or a referral, if you will, to our palliative supportive care services, which are currently involve the competency and services of Joni Williams. I'm the medical director for those services, and Joni is the RN that hopefully many of you know. Very busy in the hospital, We started an inpatient service in 2013, almost 3 years ago, a little over 3 years ago. We began offering limited to the oncology department consultations for advanced care planning in the fall of 2014. There was a hiatus with change in personnel, and that now has been rolled out and is available to every provider at the McFarland Clinic and at Mary Greeley to have a conversation with Joni. And we also rolled out specific materials, both written and in video form, with regards to the do not resuscitate discussion for any patient at Mary Greeley or at McFarland Clinic. And Joni Williams has provided that service on several occasions to help families make that decision, being informed about what CPR is and what it can and can't do. So those are resources available right now in this medical community. This is an article that was published in the Annals of Internal Medicine, and they simply had this tote sheet that outlined a number of different aids that are available. I won't go through all of them and what they do. But it illustrates, I hope, that you can see that there are a multitude of resources, and I think that's good, because I don't think everybody responds to the same information in the same way. I'll highlight just a few of them. This was actually a brief that was paid for by the AHRQ through the Minnesota Evidence-Based Practice Center, are the ones that gathered the information, and this is the citation for that particular article. These are some of the websites that they talk about. My Directives is a website to help in decision making. 5 Wishes is a form that's been around for a very long time. People may have seen the baby blue booklets around called 5 Wishes, and I'll mention that one more time and a little bit more specifics. So that's a document that's been around for quite a long time. One of the best toolkits, in part because it's so detailed, as you'd expect attorneys to be, is the American Bar Association packet called the Consumer's Toolkit for Healthcare Advanced Planning. This is available online. We have this available to all patients that see Joni Williams. If she feels that there are people that would really like to use this tool to sit down with their proxy and sort of sort through thinking. So there are those things available. I've mentioned the Starting the Conversation Project, which is starting the conversation. There's another website that I'll mention called prepareforyourcare.org that I've looked at, very good. 5 Wishes, again, is a program that's been around for quite a long time, and these are the 5 wishes, if you will, or the 5 topics that people are invited to complete in written form. Choosing a surrogate decision maker, beginning to think about what type of treatments you do and don't want, how comfortable you want to be kept as one of the most important questions, how you want people to treat you, and what I want my loved ones to know. We've used 5 Wishes in the hospice program for many years, and it continues to be a very helpful document. The Consumer's Toolkit from the American Bar Association covers a variety of topics, which you can read here, but selecting a healthcare agent, some very interesting kind of workbook examples. Going through it is like doing math with your 4th grader. There's kind of one problem after another that you have to make a choice, but it's really well written. And that is, are some conditions worse than death? Which is really the question we're asking people to consider. How do you, when you hear odds being given, how do you respond to those? What are your values? What decisions do you want to make after your death, or want to be made for you after your death? How to start talking to your family. And I love this one. There's actually a quiz that you take in your medical proxy take, and you try to see if your medical proxy really was paying attention when you were talking to them. So this is really a nuts and bolts document, but it's very well done. What to do afterwards, and guidance for the healthcare proxies. This is a nice handbook from the organization that's been very prolific in their publications and making things available, called the Coalition for Compassionate Care of California, and something they call the Conversation Guide. And they have 3 main topics: exploring your personal views, talking with your loved ones, and making tough decisions. So that's another document that we have available and can be recommended to patients and their families. There are some academic studies that have been carried out, particularly from Dr. Sudor and her group in San Francisco. And after they explored advanced directives, they proposed that the main objective of advanced care planning should be to prepare patients and surrogates to participate in making the best possible in-the-moment decisions. So they tended to steer clear of a checklist sort of approach and to really focus on these 3 questions: choosing an appropriate surrogate decision maker, clarifying what your values are over time, and then deciding how much freedom or leeway you want to give your surrogate decision maker. Are there some decisions that you want to be absolutely under your control? I think this is something that we frequently are called on in the supportive care service at the hospital, and that is a patient that's been through a life-threatening event and are recovered, but it gives them and their families an opportunity to begin to think about, would I want to go through that again? Nobody wants to be ill, but would I make the same decision about ventilators? Would I make the same decision about staying in an intensive care? So that's always, I think, a fertile time for patients and families to look back on what they've experienced. This is a separate group that published a similar study. These are patient interviews that these are what are important to our patients. None of this should be surprising. Identifying values on past experiences, choosing surrogates wisely, decide how much leeway to give the surrogate, and then, of course, letting other people know what your decisions are to hopefully prevent conflict in the future. This is the website that I spoke of. Dr. Sudor and her group have piloted this. The paper was published about a year and a half ago. It's called Prepare for Your Care, and it's simply in website-based, goes through choosing a decision maker, deciding what matters the most, deciding on leeway, communicating, and then asking your doctor the right questions. So if you have someone who prefers to use that as a way of going through things, that's a very good website and the first of its kind. There have also been clinical trials carried out to see if certain things work. Everything sounds like a good idea, but whether it really works or not and serves its purpose, I think, is always worthy of questioning. So these are 5 studies that have been published and were sort of summarized in this article in the Journal of Clinical Oncology about 3 years ago. Dr. Temmel is known perhaps for her work with regards to palliative care and lung cancer patients out of Harvard. A prompt list for questions. That was helpful. A video about end-of-life care. Again, pretty striking differences. When people simply saw a video, there was a major shift in terms of what decisions they made about comfort care. A specific video on CPR, there was a different impact on people as they made that decision. something as simple as either talking to people or just handing them a piece of paper made a difference. Kind of striking, really, to think that the number of people who died in the hospital was more than halved if you talked to them as opposed to just handed out one more piece of paper. And then this study, in which there were prompts built into the electronic medical record, that documentation improved, the time to discussion improved. These were patients being seen in oncology practices. So it doesn't take huge expenses to make big differences in patients' decisions and behaviors. This, I hope, will be of some interest. I'll try to wrap this up in about 10 minutes and leave time for questions. These are authors that I've read. I wanted to share with you, and I find them to be speaking, to me anyway, the truth about how people are making these decisions. The first one is a piece of research, really, and interestingly shows that in physicians were asked the very same questions in both the year 1989 and the year 2013, so different generations of physicians. And amazingly enough, 88% of the physicians would choose a DNR status in this circumstance. That sounds right to me, and given the fact that almost 90% of all providers agreed, I suspect that it sounds right to most of the people in this group. The one change in those two generations is that advanced directives are more common, even though they're not as common as we'd like them to be, but that the physicians practicing nowadays have more confidence in advanced directives. There's less concern that if a patient doesn't have an advanced directive, that it's automatically an all-out, you have to do everything sort of a decision. And that's changed over time. This is an interesting article by a brief essay by a family practitioner. I'm sorry I can't give you the date of the article because it wasn't included in the copy I made. And this is the statement he makes. It's not a frequent topic of discussion, but doctors die too. And they don't die like the rest of us. What's unusual about them is not how much treatment they get compared to most Americans, but how little. And in my 30 years of practice among providers who've regrettably suffered from a malignancy, this certainly rings true. A much younger voice, Dr. Atul Gawande, published this really nice essay in the New Yorker about 6 years ago. And he talks a little bit about our responsibility as providers. So I think his is a voice that will continue to be heard. He's a superb writer and I think a superb thinker. And I look forward to reading more of his writing. People die only once. They have no experience to draw upon. They need us, doctors and nurses, who are willing to have the hard conversations and discussions and to say what they have seen, who will help people prepare for what is to come and to escape a warehoused oblivion that few really want. And so he charges us as providers to not take a totally neutral stance, but at least to offer what we observe in families and patients who are been faced with this decision. Dr. Newland is a surgeon who wrote a very well-known book. I've forgotten, it was published so long ago, it didn't seem that long ago until I looked at the publication date and How We Die. This is his conclusion near the very end of the book. I will not allow a specialist to decide when I let go. I will choose my own way, or at least make the elements of my own way so clear that the choice, should I be unable, can be made by those who know me best. I will not die later than I should, simply for the senseless reason that a highly skilled technological physician does not understand who I am. Quite an indictment, I think, and eloquent as well. A much more recent article by a physician who is also a very prominent voice in American medicine, particularly American bioethics, is Dr. Ezekiel Emanuel, who was the director of ethics at the National Cancer Institute. He wrote a fairly lengthy article, and the title really says it all. Why I Hope to Die at 75. An argument that society and families and you will be better off if nature takes its course swiftly and promptly. And his essay is his defense of that statement, of that conclusion. He starts with some of the facts as he sees them, as the literature reviews it, and that is Americans may live longer than their parents, but the truth is that we may be more likely to be incapacitated for a longer length of time than our parents. He doesn't find that very desirable. That there is a notion called compression of mortality that he says is quintessentially an American idea, what he calls the American immortal. It tells us just what we want to believe. We'll live longer lives, and then we'll abruptly die with hardly any aches, pains, or physical deterioration. It's this dream, or as he labels it, this fantasy, which drives the American immortal. And then his conclusion, I think this manic desperation to endlessly extend life is misguided and potentially destructive. So that's his take on the American view of death and advanced care planning, or lack thereof. And then he concludes that at 75 we reach that unique but somewhat arbitrarily chosen moment when we've lived a rich and complete life and have hopefully imparted the right memories to our children. And he concludes with this decision that he has shared over the objections of his family, but which he has shared: once I have lived to 75, my approach to healthcare will completely change. I won't actively end my life, but I won't try to prolong it either. Interesting. I think all of us will go back to our offices and people who have made a different choice. And again, I'm not advocating this, but I think you'll be hard-pressed to find anyone who's spent more time thinking about American healthcare, the ethics of American healthcare, and who was willing to share his own decisions, not as someone offering advice, but someone trying to make a very difficult decision and to live by that decision. Very good essay. I would recommend it to all. And then, frankly, my favorite author in the field of bioethics is a man who's now well into his 80s, a man named Daniel Callahan, who began a bioethical think tank called the Hastings Center. And these are the conclusions that he reaches in a book called The Troubled Dream of Life, published again about the same year as Dr. Newland's book. Self-respect and integrity need not, and ideally ought not, to be grounded in a capacity to control our lives in mortality. So he thinks that American immortal, if you will, is a false god. Pain and suffering can make life a misery, but an obsession to manage and to be relieved of them can corrupt us. The richest self is not the one that seeks an optimal stage of life, but is protean enough to cope with every stage, whatever it brings, as a definition of someone who truly has a rich life. This one I probably like the most. Human beings will and must be a burden on one another. The flight from dependency is a flight from humanity. So, and then there's this one about control of life and the definition of humanity. And then he goes on to discuss another book that he wrote around that time called Setting Limits. This is a memoir that he wrote, and so I'm taking from that. But he discusses this book, which is by far his most widely read and criticized and praised book. And he said, in essence, my argument is that at some point, rationing of health care of the elderly will be needed, that it should focus on expensive treatments for those over the age of 80. So he chooses that age. But also, and he emphasizes this, that enhances long-term care and economic support is necessary. Again, his argument is that by the age of 79 or 80, most people have lived long enough to have a full life, and that death at that stage and that age could be called natural. So again, someone who's at that age and has thought many, many years about the ethical parameters of these decisions. This is his priority pyramid, if you will, in a third book that he wrote called What Kind of Life? And he says this is the order that society should be spending its money. Now, this was written in 1990, so it gives you some idea of how long he's been championing this. That provision of care in its most basic form is society's top priority. And the first priority for funding. I think we can all agree that what nursing home nurses and aides are paid certainly belies the notion that this is given a high priority by our society. That nutrition, sanitation, shelter, all simple things, is also a high priority. Immunization, because of its cost-saving nature, and the treatment of infections because of its cost-saving nature and simplicity. And then emergency and primary care. So if a society did nothing more than offer these 4 levels of care in the best possible manner, in his mind, that would be a society who has fulfilled its obligations and has achieved good quality and high value medical care. Nothing more would need to be done. He admits, though, that there are other levels, but these levels take a much lower priority. In general, advanced forms of medical cure or restoration, or provision of highly advanced technological therapy. And for someone who practices at least level 5 and oftentimes level 6 on a day-to-day basis, those levels of priorities ring pretty true. It's hard to escape the notion that the $250,000 that a patient pays for a medication might be better spent on women, infant, and care programs. So those are voices that I've listened to in the years that I've participated in medicine and have been interested in this topic, and they're voices that I would certainly recommend to everyone here. Questions? Be happy to answer questions about any topic that I covered or anything else that someone would like to bring up. Otherwise, thank you very much for attending, and you get extra credit for this, I think. Todd, question? Yes, and Dr. Berryhill appropriately points out that the arrival of the electronic medical record has made it much easier for us to locate advanced directives once they're entered in. I would also say, to expand on that, that Epic, with its next iteration, so let's see, 2014 came out in the end of 2015, so I'm presuming whatever comes out in 2017 will actually be 2015, so whatever they want to call it. But the next iteration of Epic will actually have a section called Advanced Care Planning that one can even more easily refer to. But we can find the advanced directives in the electronic medical record much more easily. Other questions or comments? Jay?
Larry, that was very informative and insightful. I just got back from the WHO in Minneapolis, where I saw Pete Townsend and Roger Daltrey at ages 70 and 71 do my generation and announce that they hope they died before they got old. I struggle with the chronologic distinctions. You know, time changes things. Our understandings of how to take care of our bodies. I balk at 75 or 80 being break points. It kind of depends on how you're doing, right? I mean, there are people that are still working. I have a lady who drives to Des Moines to work at Principal. She just got or Pioneer rather. She just got laid off, but she was driving back and forth from rural Iowa to work a 40-hour work week at 89.
Yep.
And you know, there's nothing wrong with this lady.
Sure.
So I wonder if you could speak to the issue of the chronologic age
Sure.
as a milestone in your belief system.
Well, I think, so the question raised by Dr. Brown, I think, is very appropriate, which is this business of setting an arbitrary age. Everyone who writes about it agrees that it's arbitrary. I would say that if I can speak on behalf of Dr. Ezekiel Emanuel, who wrote the more recent article, his attitude was, I'm not advocating that people make rules. I'm not advocating that Medicare stop paying for things. I'm just saying that for someone who's had a chance to think about this, and he's in really good health. He just climbed Kilimanjaro. He's actively writing. But his decision is that at age 75, he's going to stop trying to prevent death from arriving by reducing substantially his consumption of health care. He's not going to take statins. He's not going to check his PSA. He doesn't check his PSA anyway. He's not going to have his blood pressure checked. And he is willing to let nature, if you will, take its course while still, you know, pursuing all those things that he loves to do. Daniel Callahan, I think, on the other hand, would say to you, you're foolish. We can't afford it. He's perfectly delighted to hear that an 89-year-old woman is driving to work. On the other hand, he thinks the society should have a stay if this 89-year-old woman is in an automobile accident and rendered into a vegetative state and is required to be placed in an institution on a ventilator for what years remain of her life. And I think one can argue the economics of that, but his argument would be we should have something to say about that. We should celebrate an 89-year-old woman's independence, and we should castigate our medical system if we put her in a nursing home with a feeding tube and consider that in any way good medicine or humane medicine. That would be his response, I think. Other questions? Pat and, Mike's got the mic.
Yeah, thanks, Larry. I particularly liked your quotes. I thought they were really interesting and good. My question is, you know, it's always said that if you want to improve something, first you have to measure that. And do we have good measures of how we're doing with advanced directives and palliative care? How do we compare, and are we improving?
Good question. So one of the issues that palliative care, supportive care has wrestled with is it sounds like such a good idea, and it feels like a really good thing we did when we sat down and had informed discussions with patients. How do we really measure it? We don't have good measures at Mary Greeley because there's nothing really built into the system very easily. You know, we don't have any good way of automatically checking off this 65-year-old has an advanced directive in his electronic medical record. We can tell what diet they ordered, but we can't really tell that. So part of it is I think deficiencies in the EPIC system because these ideas of measuring that type of quality of care just isn't embedded in the system. So it's a matter of software design. I understand the need to measure things, but you know, everyone quotes Einstein and everyone quotes who is the efficiency guy, and they all pointed out that that the most foolhardy decision one can make is to make the assumption that if it can't be measured, then it's of no importance. And of course, so I still delight in what every medical student learned, which is that even though you're not supposed to follow anecdotes, that's what we all keep in the back of our mind. So I think about families that have met with Joni Williams and have been able to make decisions about CPR status and DNR status, or to abandon further attempts at treatment, or people who've come into the hospital repeatedly from the nursing home and have made a decision to sign an I-post and aren't coming back to the hospital. It's a matter, I think, of designing systems that are able to capture that information, Mike. So right now I live on anecdotes, but hopefully we'll get to the point where we can measure things. You know, lacrosse has measured things like, you know, how many people have an advanced directive, and if people did, were they followed? And of course, Stephanie Nelson presented the information. They can ask Medicare, what did you pay for people in this Medicare region versus people in that Medicare region? So there are those kinds of measurements that you can do. Yeah, Pat, question.
Two things. One is we as the hospitals very much appreciate when the primary care physicians have been diligent about going over those advanced directives. You know, have you thought about CPR? Although sometimes we've had to make those decisions kind of on the fly, and actually we had one that was a really tough case where it hadn't been decided, or I think it had been discussed, and then you had, you know, was it ex-family member number 9 from, you know, 300 miles away came in and overrode everything. The other family got to watch as that loved one had CPR done on her and every rib was broken and, you know, blood was everywhere. And it's sad that sometimes it comes down to that moment where we make that decision. But the other part is, I think it's very short-sighted for people to say, oh, well, we're going to have this arbitrary age of, I mean, I think we're already kind of running into the point where we're looking at our society and healthcare costs continue to climb. We're not going to say that we're going to have these death panels, and I think that's very short-sighted to say, oh, well, it's death panel. But, you know, my father-in-law, he was 76. Now, he was 76 when he finally was diagnosed with prostate cancer. It was everywhere. But for 76 years, he could have had his prostate cancer diagnosed earlier, but for 76 years, he thought he was completely healthy. You know, so part of that discussion is like that 89-year-old. Too many times have I had that 89-year-old come in, and she has an insult, and now she's not back to where she was. Well, families tend to take the best functioning moment over the past year and say that's the baseline that we expect them to get to. I think being realistic about saying, I agree, celebrating that they've done that well for 89 years, that's great. But we also need to, even those patients, we need to discuss with them, you know, where are you on the continuum of how much you want to have done. I'm definitely more on the Ezekiel Emanuel side, and then it's sad that even the how doctors die. I've had a lot of patients look that up, and they realize where we are on the spectrum of how much care we want to have. But believe it or not, we even have a hard time as family members, as physicians, communicating that, not just to our patients, but even to our family members. It's very difficult. So.
Very good points, Pat. Yeah.
What is the current status here in Iowa on the death with dignity rules?
Yeah. What is it?
Where do we stand? Where does Iowa stand in terms of death with dignity policies?
Well, I'm assuming, Dirk, let me make sure I've got this clear. Are you talking about the provision of a lethal dose of a medication?
Right.
All right. So the death, well, it didn't make it out of subcommittee in the state of Iowa, and the legislature's gone home now, so there's not going to be anything that happens in 2016. You know, it's the same discussion that Oregon's had, and California just passed. That's probably the big news, is California now has a death with dignity statute. People may not be aware of it, but the entire country of Canada, by judicial decision, has begun a death with dignity process. And they're all basically based on the Oregon model, and the Oregon model is that because they were the first to do it. But in Iowa, it's been discussed, it's been advocated, and it never got out of subcommittee. So I have no doubt that for however many years it'll be brought up every year in the state of Iowa. Other questions or comments? Very good. Thanks everyone for attending.